So right now, like I said, the biggest thing that we're doing at Dartmouth is the Regional Transfer Center, and I actually got that idea last year listening to the talk from Cleveland Clinic. And I was realizing at that point that, we could never do that at Dartmouth because just our region is not set up in that we own all these hospitals. But that's where I got the idea of maybe we can do this and just make agreements with the hospitals around us, show them the benefit of giving them the volume that they need. So our regional resources is structured in such that we have the Level 1 Tertiary Care Center, which is Dartmouth, and then we have about 5 community hospitals throughout the state. And then we have many critical access hospitals throughout the state, and those are hospitals that have less than 20 licensed beds, and they have really limited ability. Their job is just to stabilize a patient and then ship them. And with us at Dartmouth, like I said, we have a unique issue of we do not have enough capacity. So we're trying to, find ways in which we can free up the beds for the patients that need them, because we are the only Level 1 tertiary care center in the state. We really want to give some of the volume back to the region and help the region and fill their beds, because we need those hospitals to stay open. Our role is not to be a community hospital, and that's kind of, some of our patients really don't need to be there. They need to be out in their community hospitals. So that's kind of our work right now and going forward, is just to utilize the regional resources so that we can do what we need to do at Dartmouth. So right now, the knee-jerk reaction is for everybody to just call Dartmouth-Hitchcock to transfer their patient from the critical access hospitals. And what that has led to is that we have capacity issues at Dartmouth, while the community hospitals have low volumes and are at risk of closing their doors. So what we've developed is a regional transfer center. And we've done this we have some of the standards best programs at Dartmouth. So when the critical access hospital needs a transfer, they will still call Dartmouth, and we will still accept the patient into our system. And then we will tell the physician, the referring physician, and it's a physician who makes this decision, who will say to the referring physician, your patient has been accepted at Dartmouth at our Cheshire location. And that they pick that location as based on closest to the patient, and if that community hospital can meet the patient's needs. So we're looking at right now having a hospital that is really strong in cardiology, another hospital that's really strong in orthopedics, so that we can determine where the patient needs to go, save our Level 1 tertiary care beds at Dartmouth, and keep the patient closer to their community. Patients really want to be closer to home. Their physicians can actually access their records. Their families can come visit them. They predict that the patients that are going to require inpatient stays are going to be sicker patients, and we're actually already seeing that. So the need for our beds are the sickest patients, and some of the patients that we get referrals from these critical access hospitals, they can go to a community hospital. They can be closer to their family, and they can have their needs met.